So we became interested in metabolic health as it relates to cancer, really based on the initial population science data, which showed a link and continues to show a link between a classical state of metabolic dysfunction, which is obesity, and the development of several different cancers. And we now know that there are at least 13 different cancers that are associated with obesity. But we're learning that there are likely more cancers that are associated with metabolic dysfunction. And when we broadly categorize metabolic dysfunction as either excess adipose tissue, excess adiposity, or insulin resistance, or some combination of those and other metabolic parameters, what we really find is nearly every cancer is impacted by metabolic dysfunction. And so I spent the initial part of my career really trying to understand the mechanisms, to your question, through which obesity and other states of metabolic dysfunction promote both carcinogenesis as well as cancer progression. And now we're also learning how metabolic dysfunction and metabolic function in general can also impact and modify the response to cancer therapies. The key mechanisms, there are several. We know that several pathways overlap between metabolic pathways, signaling pathways, and those pathways that are involved in cancer development and progression. Nearly every classical hallmark of cancer is impacted by our metabolic health. Inflammation is one that is a major mechanism through which obesity and metabolic dysfunction promote cancer progression. We know that in a state of excess adiposity or obesity, the adipose tissue itself becomes inflamed. And this is an acute, or not an acute process. This is a chronic subclinical process that can sometimes be hard to detect, and that can actually occur in people with a normal body mass index, but who have metabolic obesity. So inflammation, and particularly adipose tissue inflammation, is a key mechanism. Insulin resistance is another mechanism. We know that insulin and signaling pathways associated with insulin, as well as insulin growth factors, can induce DNA damage, leading to cancer development, and can also impact response to cancer therapies. Certain cancer therapies can also modulate insulin and insulin response. So this is another key area. We're also seeing that the microbiome plays a very important role. The gut microbiome, of course, is modulated by our lifestyles, diet, exercise, and other factors that can also directly impact cancer development. We have seen data linking this directly to colon cancer, for example, but there are, of course, links to other cancers that are not necessarily gastrointestinal cancers as well. And a number of other mechanisms. Immune modulation, I should mention, is another major mechanism that we see impacted by metabolic dysfunction, leading to either immune evasion or other attenuation of immune response that can then increase the risk of developing cancer, or can be an opportunity for using immunotherapy for cancer treatment, particularly in patients with certain types of metabolic dysfunction. For example, we know that obese individuals actually have better responses to immunotherapies. I could go on and on. There are many mechanisms, but I think those are some of the key mechanisms impacted particularly by obesity. It's a great question. So I think we're now in an era where we have to be incorporating some type of metabolic management into cancer therapy or cancer treatment planning. And this can range from lifestyle counseling, diet, exercise. It could also include management of risk factors like prediabetes, and then certainly managing some of the metabolic adverse effects of our cancer therapies. Some of our molecular therapeutics cause hyperinsulinemia, and we know, at least from preclinical models, that if you manage that hyperinsulinemia effectively, not only can you reduce the toxicity of the cancer therapy, but you can actually improve response to that therapy and potentially improve survival of the patient. So I am of the strong opinion that we need to be incorporating metabolic health management into cancer treatment. And this could be done in a number of different ways. I think that's what the field is trying to figure out right now, is how best to incorporate this type of approach. We've recently seen results from a large exercise trial in colon cancer showing that a structured exercise program improves survival and cancer-specific survival in colon cancer. So this study provides us now with gold standard randomized controlled data supporting the need to incorporate exercise as an example of metabolic health management into our cancer treatment plans. I think the barrier is, how do we implement this clinically? Right now, unfortunately, we don't have reimbursement for exercise oncology services, for example. And this is an area that many of us are working on from a policy standpoint to try to achieve this goal in a similar way that has been done with cardiac rehabilitation, for example. And so following a model like that might be successful, but in the meantime, we need to think about how can we implement metabolic health management? And this can range from lifestyle interventions like I have been discussing, even to pharmacologic interventions. We now have effective weight loss therapies, specifically the incretin mimetics, the GLP-1 receptor agonists, that are starting to be explored as tools to be used in oncology as well. I find that the most successful approach to incorporating metabolic management is multifaceted. One is I try to include endocrinology partners in the management of my patients with cancer, especially if they're on a cancer treatment that induces metabolic dysfunction. And the earlier we can include our endocrinology partners, the more likely we're going to see benefits from that approach. The other approach that I take is to start talking about metabolic health with patients early on in their cancer journey. It's easier to preemptively or prophylactically optimize someone's metabolic health before you've started to encounter metabolic disorders like diabetes and other cardiometabolic disorders. So if we can do that early in the cancer treatment journey, we'll see even more benefits. And then finally, really bringing in a multidisciplinary approach. And so we're developing clinical models and platforms that incorporate not only multidisciplinary clinicians like nutritionists, exercise physiologists, and so forth, but also that leverage digital therapeutics. And this is where we can really personalize and individualize these kind of approaches by using either AI-based technologies for risk stratification and intervention matching, or digital therapeutics that patients can work with on a daily basis, for example, virtual exercise coaching, nutrition coaching, and so forth, that can help augment our clinical services as well.